There have been a technical snag. I am restarting the session. Welcome you all to today's session where I am discussing important PYQs of the INICET examination related to my subject of cons and endo. So basically it would be a high yield session related to some of the recently asked questions in the examinations. So I hope I am well connected and my screen is also visible to you all. As you can see, the question number 1 that is displayed onto the screens. What can be used for pulp protection in a tooth with an uncomplicated crown fracture involving the dentine? So again, I'm stressing the fact that for your examinations, dental traumatology is a very important topic. And recently you must have appeared for the NEET MDS also, and must have seen that couple of questions have come from there. So it is talking about an uncomplicated crown fracture. Means uncomplicated crown fracture simply means there is involvement of enamel and dentine, but no pulp exposure has occurred. Okay, enamel and dentine is involved. So basically what is happening, there is a tooth. This is the pulp chamber of the tooth. This is the enamel cap on the tooth, and the fracture line is going like this, which is involving the enamel and dentine, resulting in uncomplicated crown fracture. What is the agent used for pulp protection, it is asking. The options are dentine bonding agent, light cured GIC, chemically cured calcium hydroxide, light cured calcium hydroxide. Now, basically, whenever we talk about uncomplicated crown fracture, an important thing that we have to keep in mind is remaining dentine thickness. RDT means how much of the dentine is remaining above the pulp. That would decide the treatment of choice. Okay, the remaining dentine thickness, it can be greater than 0.5 millimeter or it can be less than 0.5 millimeter. These are the threshold values, whether it is less than or more than 0.5 millimeter. When it is more than 0.5 millimeter, we generally do not require any form of pulp protection and restoration of choice can be done. Simplest way of answering these questions. But whenever the remaining dentine thickness is less than 0.5 millimeter, we require some sort of pulp protection. As you can see from the language of the question, nothing is mentioned about the remaining dentine thickness, but it is asking about pulp protection. So when the pulp protection is involved, definitely it is talking about something that is less than 0.5 millimeter. So pulp protection in such situations requires some sort of medicament like calcium hydroxide. So we would rule out the options A and B, that is light cured GIC and dentine bonding agents. We are left with options C and D. Both are based upon calcium hydroxide, but we know that light cured calcium hydroxide is a better suited material because it is more in the hand of the clinician, that it sets with command. Okay, as compared to chemically cured calcium hydroxide, light cured calcium hydroxide is the preferred agent. So what would be the suitable answer? Option D would be the suitable answer to this question. Okay, this is how we talk about uncomplicated crown fractures. We have to do some sort of dentine capping by way of pulp protection. Coming over to question number 2 as displayed onto your screens. The perforation in which region of the root has the best prognosis? It is talking about perforation and iatrogenic error, that is perforation. Perforation can be iatrogenic or pathological perforation, but it is asking about best prognosis. So in general, we can talk about the prognosis of tooth with perforation. Okay, if this is a tooth, the prognosis increases from cervical to apical. This is the prognosis increases. This is the sequence that you have to remember. Any perforation which is occurring in the furcation area or cervical area has got the worst prognosis. Perforation occurring in the middle 1/3 area has a better prognosis, and perforation occurring entirely into the healthy bone in the apical 1/3 have a best prognosis. Though it is asking about which perforation would be having a best prognosis, then the answer would be apical 1/3. Option A. If we have to talk about the sequence of best prognosis to worst prognosis in this question, then option A has got the best prognosis, followed by option C, followed by option D, and followed by option B. From best to worst prognosis. Okay. Best to the worst prognosis, the sequence of prognosis. You can remember as we go down from the tooth surface. Why this is happening? Because in the cervical areas, there is junctional epithelium, and whenever the perforation occurs, the communication is between the pulp and the PDL, as well as there is a lot of tissue fluid coming from the gingival sulcus, which makes the area quite infected and the prognosis is guarded. So this is the sequence of prognosis for perforations. So answer would be best prognosis apical 1/3. Okay. Coming over to question number 3 as displayed onto your screens. In which type of suture material is microbial transmission and the wicking effect is evident? Wicking effect means suction of the tissue fluids. What type of suture impairs the wound healing by having a wicking effect or capillary action? Options are synthetic monofilament sutures, plain gut sutures, Teflon sutures, and silk sutures. I think the answer should be very much obvious. These silk sutures, they are normally braided. Braided means they are multifilament. When these sutures are braided or multifilament, they suck the tissue fluid and microbes from the saliva and impair the wound healing. So answer would be option D, that is silk sutures. They have got a wicking effect and microbial transmission. That's why it is advised that after periapical surgery or endodontic surgery, the sutures should be removed as early as possible. Previously, we used to wait for 7 to 10 days for suture removal. The contemporary evidence suggests that it should be removed within 24 to 72 hours at max. 1 to 3 days the suture should be removed so that initial apposition of the tissue margin occurs, but the sutures is not there for long enough to cause wicking and microbial infection. Okay. Question number 4. What is the recommended treatment period for lateral luxation? Lateral luxation, it is a type of concussion injury where the tooth is displaced either labially, lingually, mesially, or distally. Okay, it is basically lodged into one of the bones, okay, into the socket bones in one of the walls of the bones. So options are rigid splint for 2 weeks, flexible splint for 4 weeks, rigid splint for 4 weeks, and flexible splint for 2 weeks. All of you must be remembering it that we always give physiological, non-rigid or flexible splinting. So we rule out the options A and C straightforward. We are left with option B, which are flexible splint for 4 weeks and flexible splint for 2 weeks. For that, you should know the duration of splinting for lateral luxation is 4 weeks. So option B would be the answer. Normally, the duration of splinting is 4 weeks for lateral luxation and intrusion type of luxation injuries. And it is 2 weeks for subluxation and extrusion. Okay. So these are the 4 types of luxation injuries. So you have to remember just 2 time frames. One is 2 weeks, one is 4 weeks. 4 weeks is recommended for intrusion and lateral luxation, and 2 weeks is recommended for your extrusion and subluxation. And always the type of splinting remains the same, that is non-rigid, flexible, or physiological splinting, so that no tooth ankylosis occurs. Okay. So what would be the answer? Answer to this particular question would be option B. Okay. Coming over to question number 5. According to Vertuse's classification, which type describes a root with a single canal that splits into two canals? A relatively straightforward question which you can answer if you remember the Vertuse's classification into 8 canal configurations. Okay, it is basically asking with a tooth, single root, a single canal that splits into two in canals, 1, 2 configuration. Okay, so it is basically Vertuse type 5, isn't it? So 1, 2 configuration is Vertuse type 5. Option A would be the answer to this question. Okay, I would quickly tell you the Vertuse classification. Type 1 vertex is designated as 1 configuration. Type 2 is 2-1 configuration. Type 3 is 1-2-1 configuration. Type 4 is 2 configuration. Type 5 according to vertex is 1-2 configuration that was asked in the question. Type 6 according to vertex is 2-1-2 configuration. Type 7 according to vertex is 1-2-1-2 configuration, and type 8 according to what you see is 3 configuration. This already you must be aware. So this is what you see type 1 through type 8 canal configurations. The question is asking a single canal that splits into two. So 1-2 configuration, type 5, option A is the answer over here. And you should also remember that it is the maxillary second premolar. It is the only tooth in the oral cavity that exhibits all the 8 possible vertice canal configurations. Maxillary, second premolar. All 8 types are demonstrated in this. Okay. Coming over to question number 6, as displayed onto your screens, a patient with pulp exposure has calcium hydroxide applied directly to the exposed pulp to preserve its vitality. What is this procedure called? A very, very simple and straightforward question. It is a form of vital pulp therapy called direct pulp capping. Options are indirect pulp capping, direct pulp capping, partial pulpotomy, or square pulpotomy. Okay. These two are basically the same options. What it is talking about, calcium hydroxide is applied directly to the exposed pulp, so it is a form of direct pulp capping. Option C is the answer. Nothing much to explain over here. Coming over to question number 7. The thickness of MTA plug-in apexification is thickness of MTA plug-in apexification is 1 to 3 millimeters, 3 to 5, 5 to 7, or depends upon the root length. See, apexification is the conventional treatment for immature pulpless teeth. What type of treatment it is? It is conventional treatment or old treatment. Whenever we find a situation of immature pulpless tooth, the contemporary treatment would be regenerative endodontic procedures. Okay, so if you encounter a question, what is the treatment of choice for a tooth with open apex and non-vital status, then the treatment of choice would be pulp regeneration, regenerative endodontic procedures, pulp revascularization, or similar terms. Here it is asking about the thickness of MTA plug. So we make an apical MTA plug that is 4 to 5 millimeter thick. This is the usual thing that we make. So if we look at the range 4 to 5 millimeter, the best possible answer would be option B. What is the thickness of apical MTA plug? It is in the range of 4 to 5 millimeters. Question number 8. The best prognosis of repair among root perforations. The best prognosis of repair. Now, if you look at the previous question, it was asking best prognosis of which perforation is there. Now it is asking best prognosis of repair, means best possible repair. Which area of the perforation, which location of the perforation is most readily accessible to the clinician to apply the repair material? So there is a slightly different, it is not asking you about the prognosis of the perforation site, which we have already discussed previously. It is asking about prognosis of attempting to repair the perforation. The prognosis would be best for the most accessible or approachable perforation. So it would be for what type of furcation? Furcation area perforations. Best prognosis of repair. Okay. And otherwise, best prognosis would be which type of perforation? Apical one-third. See, apical one-third perforation, if we attempt to repair, it is very difficult area to reach, isn't it? The tooth root is surrounded by bone all over. So it is very, very difficult. We have to expose the tooth root surgically and then attempt repair. Here, the repair is easier. Best possible repair is for the furcation area. Coming over to question number 9. Type 3 apical transportation of canal is best repaired by. Now, if you can see, a couple of questions have come to endodontic mishaps. So this is a pattern of INICET that they would ask you more clinically advanced topics as compared to your NEET examinations, isn't it? It is asking about apical transportation treatment. There are basically three types of transportation. Type 1, which is a minor apical transportation. Type 2, which is a moderate type of apical transportation, and type 3, which is a severe type of apical transportation. You understand what is apical transportation? This is a curved root canal, suppose. Okay, and this is the apical foramen that was originally present. But because of inappropriate cleaning and shaping, using of stiffer instruments inside the root canals, not following the canal curvature, or other procedural errors, what is happening? There is relocation of this apical foramen onto the external surface of the root. There is widening of the apical foramen in a way. There is transportation of the apical foramen. So type 1 minor, it requires simply reshaping of canals with larger files. Okay, reshaping of canals with larger files, slightly short of working length. Okay, nothing much is required. You would realize that a type 1 transportation has occurred. You would shorten the working length by 0.5 to 1 millimeter depending upon the location, and then do cleaning and shaping again so that a new apical stock is created in the apical one-third. Type 2, which is a moderate type of apical transportation, its treatment involves repair with a suitable material. We have to repair it. The transportation is so large that simply by changing the working length and enlarging with larger instruments would not help. We have to take care, we have to address the site of transportation by using a suitable repair material and barrier material. So if this is the apical transportation that has occurred, This is the location. We would insert some barrier material, and against the barrier material, we would put the repair material. Repair material can be anything like empty or similar materials. Barrier can be resorbable or non-resorbable barriers. Okay. And whenever type 3 or severe type of transportation occurs, simply placing a barrier material and attempting to repair would not help. We have to do surgical correction. So these are the three types of apical transportations and their respective treatments. The question is asking about type 3. Option A is MTA plug. This is for type 2. Surgical correction and apical resection. This is for type 3. Epexification can be for type 2. Placement of a repair material. Warm vertical compaction is not. Extraction is not. So what would be the answer? Answer would be option B. So I have principally told you all the three types of apical transportations and their respective treatments. Question number 10. The best treatment for cracked tooth with reversible pulpitis. There is a tooth crack. There is a crack in the tooth. Incomplete fracture. Crack is with reversible pulpitis. Reversible pulpitis means pulp hyperemia. There is a case of pulp hyperemia. Best treatment it is asking about: full coverage crown, resin or composite restoration, bidirectional splint, and single splinting or stainless steel splint. See, all of them can be attempted as treatments, but the best treatment is a full coverage crown, because when we place a full coverage crown onto a cracked tooth, there would be no possibility of even the microscopic movement of the fracture segments, crack segments. Okay. So this full coverage crown would be giving a reinforcement to the coronal tooth structure. The crack in the tooth would not become complete or progress further, and the symptoms related to that would be alleviated. So what would be the best treatment? Full coverage crown. Option A would be the answer over here. Coming over to question number 11. I think this is a repeat of the question that we have previously discussed. It is asking about uncomplicated crown fracture. To avoid pulpal inflammation, it would be calcium hydroxide light cured. Okay. Option A would be the answer. I have already explained it. Coming over to question number 12. For severely intruded tooth, another type of luxation injury with closed apex, when should the root canal treatment be done? Okay, we know that intrusion is the most severe form of luxation injury. Luxation injuries, severity: concussion, then subluxation, then lateral luxation, then extrusion, and then intrusion. The severity of the injuries increases like this. Concussion is the least severe, intrusion is the most severe type of luxation injury. And moreover, it is a severely intruded tooth with a closed apex. Tooth can have an open apex or a closed apex. When should be the root canal treatment be done? A tooth has become intruded, which is fully formed tooth. Then there would be damage to the apical neurovascular bundle, resulting in pulp necrosis. The necrosis of pulp is highly likely to occur in a severely intruded tooth, which is the most severe form of luxation injury. So whenever necrotic pulp is there, it can be a source of inflammation to the periapical tissues, resulting in external inflammatory resorption. So what is the treatment? After positioning the tooth and splinting the tooth. What would be the duration of splinting? It would be 4 weeks of semi-rigid splinting we have seen above. We have to do the root canal treatment at the earliest time frame to prevent the necrotic pulp from infecting and inducing inflammatory root resorption. So root canal treatment should be done as early as possible. Now we come and look at the options. After 4 weeks, no, it should be done at the earliest time. Immediately after repositioning, within 2 weeks, or only when the patient complains of pain. No, because severe intrusion, pulp necrosis is highly likely. So option A and D are ruled out. We are left with options B and C. Immediately after repositioning or within 2 weeks. Normally, the time something is true. Sorry for the technical snag. Normally, the time frame is 7 to 10 days after splinting. 7 to 10 days after splinting, we initiate the root canal therapy. So, within 2 weeks is the best possible answer to this question. Okay, 7 to 10 days within 2 weeks. C. I hope all of you understand. Coming over to question number 13. A tooth with lateral luxation. So many questions related to dental traumatology. Lateral luxation over a decade back now is showing discoloration. Means the tooth is becoming non-vital now. The patient is asymptomatic. On IOPA, there is obliteration of the pulp canal and the periapical index score is 2. What is the treatment? Wait and watch, RCT, pulpotomy. Now, there are a couple of things related to this. There's a tooth which has become discolored, means it is non-vital tooth that requires root canal treatment. But when the IOP of the tooth was obtained, there is obliteration of the pulp canal, means due to a long-standing history of dental trauma, the calcification of the canal has occurred, and it is highly unlikely that we will not be able to negotiate the canal. The periapical index score is 2, means there is widening of the PDL ligament with mild pathology. What is the treatment? Wait and watch, do RCT, or do pulpotomy. See, pulpotomy is the procedure of vital pulp. When there is obliteration and discoloration, means the pulp is non-vital, it is ruled out. We are left with options wait and watch and do root canal treatment. Now, ideal approach is to attempt root canal treatment. But in this question, the caveat is in IOPA, there is obliteration of the pulp canal space. So whenever there is obliteration of the pulp canal space and the tooth is asymptomatic, there is no need to go for root canal in the first instance. We have to do wait and watch and see whether the tooth becomes symptomatic over time or there is increase in the periapical index score. If such thing happens, we have to do surgical intervention because it would not be possible to negotiate the root canal. So two things that are ruling out root canal treatment in such cases are the tooth is firstly asymptomatic and there is obliteration of the pulp canal space. Both of them make root canal treatment non-feasible. So the best answer to this question would be wait and watch. In the recall, only 3 options have been given. If suppose the fourth option was surgery, periapical surgery or periradicular surgery, then this would be the answer. Because already we are seeing that there is a periapical lesion in the tooth. I hope all of you understand what is the sequence of events which is happening. Okay. Question number 14. The sodium hypochlorite irrigation depends on or is influenced by what factors: pH, temperature, volume, and concentration. See, whenever we talk about irrigation, the most important irrigating action is flushing of the root canals. We have to do flushing of the root canals. See, flushing of the root canal means copious volume of irrigation should be there. Definitely volume is there. Okay, and we thought that sodium hypochlorite efficacy is directly proportional to the temperature. As we increase the temperature, the efficacy is doubled for every centigrade rise of temperature. Okay, we increase the temperature by 1 degree Celsius. We use a heated form of sodium hypochlorite. The efficacy increases by twice for every degree rise of temperature. So temperature and volume, B and C, they are the more specific and important parameters. So we look at the options: A and B, B and C, A and C, B and D. The best combination is option B, that is B and C, volume and temperature. Concentration may have an effect, okay, but it is not very significant, ranging from 0.5% to 5.5% we can use sodium hypochlorite. The concentration do have an effect, but it is not very significant. The two most significant factors, the first one is always volume. The second one would be temperature. So specific irrigant we are talking about, temperature and volume, B and C would be the answer. Question number 15. I think this is a repeat of what you see: canal, single canal into type 5. This we have already discussed. Question number 16. The root canal morphology of mesiobuccal root of maxillary molar is influenced by or depends upon what? Root canal morphology. Okay. Distance between MB1 and MB2 canals, depth of MB2 canal, length of mesiobuccal canal, root, or angulation of mesiobuccal root. It is talking about the morphology. If we see it from a maxillary molar, from a mesial aspect, okay, the mesiobuccal root is something like this. This would be the palatal root. We are seeing it from the mesial aspect. This is mesiobuccal root. Now it is asking what factors influence the morphology of mesiobuccal root. This mesiobuccal root, when seen from above, okay, the cross section would be slightly like this. Mesial side, distal side, there is a concavity on the distal side, and depending upon the distance between MB1 and MB2 canals, the morphology changes. If they are very close together, it would be more or less ovoid. When the distance increases, it becomes, mesiobuccal root becomes like kidney bean shape. So the morphology of the mesiobuccal root depends upon the distance between MB1 and MB2 canals. Option A. There have been questions related to this also, another way also. What is the location of the mesiobuccal canal? MB2 canal. So in a maxillary molar, if we look at the occlusal surface, mesial side, distal, buccal and the palatal side, this is the oblique ridge. Okay. This would be the MB1. This is distobuccal. This is palatal. And here MB2 would be located. MB2 is also called mesiopalatal canal. Okay, this is MB1, this is MB2. Both are present in the mesiobuccal root. Usually the distance is 3.5 millimeter palatally and 2.2 millimeter mesially. Okay, this is MB1 orifice. This is MB2. The distance is 3 millimeters or 3.5 millimeters palatal and 2.2 millimeters mesially. Average distance between the MB1 and MB2. Okay, it is located mesially and palatally to the principal mesiobuccal canal. 3.5 millimeters, the extent is palatally, and 2.2 millimeters is the distance mesially. Question number 17. The material used for air abrasive polishing is. It's not asking about air abrasion. It is asking about polishing, and definitely sodium bicarbonate. If simply air abrasion is there, then it would be aluminum oxide particles, 25 microns in dimension, kinetic cavity preparation. So please understand the difference between air polishing and air abrasion. Here, both the terms are combined, air abrasive polishing. But since it is asking about polishing, that is the particle that we use is sodium bicarbonate. Okay, option B would be the answer. Anyways, alumina is not there in the options, so there was no need for getting confused. We can simply answer it, sodium bicarbonate. Okay. We look at the another set of questions which have been recently asked. Okay. Hmm. Identify the burr shown in the image. We have to identify the burr. Simply air abrasion, yes, it would be aluminum oxide. Air abrasion or sono abrasion or kinetic cavity preparation. Someone has asked me whether it would be alumina. Yes, it would be alumina only for air abrasion. When it is asking about air polishing, it would be sodium bicarbonate. Okay, so there is a two type of particles that we use in these two situations. Now, identify the burr that is shown in the image. I think everyone can identify it. This is used for amalgam tooth preparations. That is number 245 burr. The length of the burr head is 3 millimeter. The diameter is 0.8 millimeter. And it has the shape that is called truncated. The shape of the burr head is called truncated cone. Okay. Someone is saying 169 Albert. No, it is not 169 Albert. It is number 245 burr. Okay. Number 245 burr, which is got shape of truncated cone. Truncated cone means the edges of the burr are rounded to make the internal line angles of amalgam tooth preparation rounded. This is used for the principal instrument for dental amalgam tooth preparations. It is number 245 burr. Number 271 burr that is used for inlay tooth preparations would be something like this. I hope you can appreciate the difference in the shape of this is a tapered fissure burr with a flat end. The length of the burr head is 3 millimeter, diameter is 0.8 millimeter. Okay, the dimensions of number 271 burr and number 245 burr are the same. Okay, number 169 L burr is used for preparation of proximal retention grooves. It would be something like this, number 271 burr, but smaller, 0.5 millimeter as against 0.8 millimeter. And number 330 burr is a small pear-shaped burr. Pear-shaped burr means it is something like this, shape of a pear. This is also used for most conservative amalgam tooth preparations. Which burr? Number 330 burr. So what is shown in the question? Number 245 burr. So there are two burrs which are used for amalgam tooth preparations. One is number 245 burr, and the most conservative amalgam tooth preparations are given with a pear-shaped version, that is number 330 burr. Number 271 burr is used for inlay tooth preparations, and number 169L burr is used for proximal retention grooves, both for cast metal preparations and for amalgam preparations. Okay. Question number 3. Identify the instruments shown in the image provided. What is it? It is an example of a regular dental explorer that is used. It has got two tips. This is number 23 and this is number 17. Something everyone must be knowing. Okay. So number 17 and 23. Option C would be the answer. Okay. Your regular operative explorer is there, which has got two ends. One is number 17 end and another is number 23 end. Explorer. It is an explorer. So option C would be the answer. Okay. What is the composition of cry paste? Although it is not related to this, cry paste is composition of your zinc oxide, camphor, iodoform, thiamol, and lanolin, parachlorophenol, camphor, menthol. It is parachlorophenol, iodoform, menthol, and camphor. Option C is the answer, something that you have to learn. It is what? It is a root canal sealer. Question number 5. All of the following are goals of regenerative endodontic procedures except which is not the goal of REP, regenerative endodontic procedures. Elimination of clinical signs and symptoms, definitely. Whatever treatment we are doing, it should make the tooth asymptomatic and functional. So it is a goal. Increase in length and canal diameter. See, regenerative endodontic procedures are attempted for immature pulpless teeth. So increasing in canal length and diameter, root canal length and diameter is definitely a goal, a desirable goal that we need from regenerative endodontic procedures. This goal is not possible with conventional treatment, that is epexification. Epexification would simply form a apical calcific barrier. There would be no increase in the length and thickness of the root canal wall. Positive pulp vitality response. Although it is very difficult to achieve, but yes, this is one of the goals because we are talking about regenerative endodontic, means the pulp should regenerate in a non-vital tooth and it should become responsive to pulp vitality testing methods. Complete obliteration of the root canal, definitely this is not the goal. We do not want the root canal to become obliterated or obstructed. So option D would be the answer. This is not the goal of regenerative endodontic procedure. So 1, 2, 3. And what is the fourth goal that we normally advise is resolution of periapical pathology. These are the four goals that we achieve with regenerative endodontic procedures. there can be set of questions. So this is the fourth option that I have given you. What are the aims? There would be increase in length of the root. There would be increase in thickness of the root. There would be resolution of periapical pathology. There would be development of pulp, and there would be what we can say apical closure. Okay. In an immature pulpless tooth, whenever we attempt regenerative endodontic procedures, we aim to achieve these goals. And which is the most difficult or elusive goal? Positive pulp vitality response. Okay. This is most difficult to achieve, but definitely is one of the goals. Obliteration of the root canal is not the goal, so it would be the answer over here. Okay. According to WHO classification, what does code KO 4.4 represent? See, for the pulpal and periapical conditions, there is a particular coding given by WHO. It starts from KO 4.0, which indicates pulpitis. Then KO 4.1, it indicates pulp necrosis. KO 4.2, KO, code number KO 4.2 indicates pulp degeneration. And KO 4.3 indicates pulp calcification. Pulp canal calcification or obliteration. Then KO 4.4 indicates acute apical periodontitis. KO 4.5 indicates chronic apical periodontitis. KO 4.6 indicates apical abscess formation with sinus. Okay. This sinus can be opening or located into maxillary antrum. The code is given KO 4.60. When the opening of the sinus is into the nasal floor, the code given is subcode KO 4.61. When there is a periapical abscess and the sinus is opening in the oral vestibule. Vestibule of the oral cavity, the subcode given is 4.62. And when the sinus opens onto the skin from the maxillary or the mandibular tooth, subcode given is 4.63. Okay, so basically code 4.6 represents apical abscess with sinus, and depending upon the location of the sinus, these are the various subcodes. Then the code KO 4.7, okay, is for apical abscess formation, but no sinus, without sinus. There is a case of periapical abscess, but no sinus is formed. And finally, code KO 4.8 is given for periapical cyst. Periradicular cyst. It is also given into subcodes KO 4.80, 4.80, which is for apical cyst. Okay, code KO 4.81 is given for residual cyst. And code KO 4.82, 4.82 is given for inflammatory periodontal cyst. So depending on the code KO 4.0, 4.1, 4.2, and 4.3, they are for the pulpal conditions, pulpitis, okay, pulp necrosis, pulp degeneration, and pulp canal calcifications. And KO 4.4 to 4.8, they are for periapical pathologies. The question is asking about KO 4.4, so it would be what? Acute apical periodontitis, KO 4.4, acute apical periodontitis. Option D would be the answer. Okay. Question number 7. In lateral condensation of Gattaparcha, the spreader should be placed to the radiographic working length 0.5 to 1 mm short of the working length, 1 to 2 mm short of the working length, the anatomical working length. In cold lateral compaction, we know that spreader is used and it should be 1 to 2 mm short of the working length. Okay, very well explained in the class notes also. The spreader should not reach the working length, but it should be 1 to 2 mm short of the working length. Option C would be the answer here. Question number 8. What is the concentration of silver diamine fluoride that has proven anti-caries activity? Now, silver diamine fluoride is a solution that is used for not only anti-caries activity, but also it is anti-hypersensitive. Two functions are there. We use 38% solution of silver diamine fluoride, which consists of effective 44,800 ppm fluoride. So question has been asked in both the ways: concentration, percentage, and fluoride concentration. Nearly 45,000 ppm or 44,800 very specifically of available fluoride is present in silver diamine fluoride, which is anti-caries agent. It is a black color solution. The caries is excavated and this solution is painted, and it also prevents dentinal hypersensitivity. This question number 9 is a repeat of what we have already seen. This is also a repeat. The current evidence for anti-caries activity of silver diamine fluoride concentration is 38% that we already see. Okay. Question number 11. All are reasonably true for post space preparation except. Okay. All are reasonably true for post space preparation or post preparation except. It is a little bit technical. Should be at least 4 millimeter apical to the crest of the alveolar bone for minimization of dentine stress. Okay. See, suppose there is a tooth like this, a broken down tooth. This is the alveolar bone around the tooth. This is the root canal orifice. And whenever we are planning to place a post, the post is extended like this so that the length of post below the root canal orifice is maximum 7 millimeter. The length of the post below the root canal orifice. The length of the post below the crest of the alveolar bone should be minimum 4 millimeters. This is at least and this is at max. These are the two dimensions relative to the root canal orifice and the crest of the alveolar bone. It is not the total length of the post, but it is the length of the post that should extend below the root canal orifice should be maximum 7 millimeters. Extending below the crest of the alveolar bone should be minimum 4 millimeter. So it should go at least 4 millimeter apical to the crest of the alveolar bone is true. Okay. In an average rooted tooth should go inside the canal by 1/3 of the root length. Okay, average rooted tooth, the post should be as long as possible. Should be 2/3 to 3/4 of root length. Some of the parameters related to the post. So it should not be by 1/3. It should be 2/3 to 3/4. This option is not correct. We'll look at the other options. Should go up to 7 millimeter in molar roots inside the canal from the chamber floor. This we have already seen. The length of the post below the root canal orifice should be 7 millimeter. This option is also correct. In average length roots, the post should be prepared so that 5 millimeter apical plug of Gattaparcha remains inside the root canal. Yes, 4 to 5 millimeter apical Gattaparcha seal should be there. Okay, and if these are given as separate options, 5 millimeter. So this option B is not correct and is the answer here. So how much should be the total length of the post? It should be for a regular single rooted tooth, it should be 2/3, 3/4 of the root length, which makes option B incorrect. It is saying it is 1/3 of the root length. No, it should be 2/3 to 3/4 of the root length. Whenever we talk about posterior teeth like molars, the length of the post, if this is the entire post, this is the root canal orifice, the length of the post below the root canal orifice should be maximum 7 millimeters, because beyond 7 millimeters there are curvatures in the root canal and post is placed only in the straight portion of the root canal. Similarly, we have to see the length of the post with respect to the crest of the alveolar bone. It should be extended at least 4 millimeter apical to the crest of the alveolar bone, which makes option A correct. So out of the four options, option B is incorrect. So is the answer over here. Okay, it was a little bit of technical, but if you have gone through the class notes, majority of the thing have been there in the class notes, you would have been able to answer this question very well. Okay, all are true regarding ideal properties of root canal filling material. Should never resorb, should slightly contract after setting. All are true regarding ideal properties. This is an incomplete question and it should be like set, which is not correct. Definitely it should never resorb. It should be there for always permanent. It should slightly contract after setting is not correct. If the material that we are using for obturation of the root canal would contract, it would create gap with the wall of the root canal, a channel for micro leakages there that can lead to failure of the root canal. Slight expansion of the material is, I would say, desirable. Okay, slight expansion of such materials occurs with calcium silicate based materials like MTA based materials, which undergo slight expansion of about 0.4% by volume. So they would better the seal with the wall of the root canal. That is what the problem with zinc oxide eugenol happens. It undergoes setting contraction. It would contract upon setting, pull away from the wall of the root canals, and create a gap with the wall of the root canal and channel for micro leakage. So it should not contract. This is not desirable. Option B would be the answer. Which is true regarding post space preparation? Okay, another question related to the post space preparation. Okay, which is true? We have to find the right answer. That was about accept. This is about which is true. And cutting burr is used? No. If we are using an and cutting burr, it would cause perforation in the root canal. It should be a safe cutting burr, non-cutting tip, like piezo reamers we are using with non-cutting tips, so that they negotiate the anatomy of the root canal without causing any perforation in the root canal. Increased diameter increases the retention and is recommended method to increase the retention. Is it true? If we increase the diameter of the post, it would increase the retention and is the recommended method to increase the retention. This portion is correct, first half of the sentence. But second half of the sentence is not correct because the best method to increase the retention of post in the root canal is to increase the length of the post. It should be 2/3 to 3/4 of the root length. So option B is incorrect. For molars, one has to be careful in preparation of the distal aspect of mesial root, and mesial aspect of distal root as concavities might be there. Okay, this is correct. Okay, especially for mandibular molars, it is got like this: the mesial root, the distal root, this concavity on the distal aspect of the mesial root and mesial aspect of the distal root. Perforations can occur. Option D. The depth of post space preparation should be kept to as minimum or as less as possible. This is against the fundamental concept. The post should be as long as possible. This option is also not correct. So out of the four options, option C is the correct one. So is the answer over here, as the question is asking about which is true. Okay. Okay. Another question. The root and preparation during microsurgical endodontics is done by ultrasonics at. We know that whenever we do periapical surgery, we have to prepare the root end. Root end preparation can be done with ultrasonics. It can be done with lasers. It can be done with burr and handpiece. When we are using ultrasonics, what should be the method? High power with water coolant, high power without water coolant, low power with water coolant, or low power without water coolant. Option C would be the answer. We have to use low power with water coolant. Why low power? Because ultrasonic root end preparation has the potential to cause root end fractures due to vibration of the ultrasonic tip. A related question came in your NEET examination a few days back that you gave. Okay, there it was asking what is the most common side effect of ultrasonic root end preparations. The most common side effect is the root fractures can happen due to ultrasonic vibration. So to prevent the root fractures, we have to use low power setting and with a water coolant to dissipate the heat that is generated due to ultrasonic vibration. Okay, so option C would be the answer here. Someone is asking me perforation risk factors in which cases. There are perforation risk factors related to the anatomy of the tooth. The most typical examples of perforations are the maxillary first premolars, where there is a mesial concavity in the root, your mandibular incisors, which are very thin mesiodistally, your mesial root of the mandibular molars because of curvature and danger zone or concavity on the distal side. So these are some of the examples of perforations that can occur. Question number 15. Which is not critical regarding perforation repair? Level of perforation, the time elapsed, the size, the nature of perforation, pathologic versus iatrogenic. Which is not critical? See, level definitely, whether it is in the furcation area, whether it is cervical, middle or apical 1/3, we have seen the prognosis decreases from the crown, increases from the crown to the root. Okay, so level of perforation definitely affects, is critical. Time elapsed. What is meant by time elapsed? If suppose perforation has occurred, it should be repaired immediately. We should not wait, because if we wait for perforation repair, then what would happen? There would be formation of inflammatory tissue and granulation tissue that would jeopardize the treatment outcome. So it should be repaired immediately. Time elapsed is the most critical factor. So if the question is asking which factor is most crucial regarding the prognosis of perforation, location of perforation, size of perforation, the time between perforation and treatment, time is the most critical factor. Okay, most crucial factor. Size of perforation, definitely smaller perforations, better prognosis, larger perforations, poor prognosis. Nature of perforation, whether it is pathologic or iatrogenic, they more or less have the same outcome. There is communication between the pulp canal and the PDL. There would be formation of inflammatory granulomatous tissue that would impair the healing. So it does not affect the outcome. It is not critical. Level, time elapsed, and size, definitely they are critical factors. Okay, whether it is happening in the apical or the cornal area, what is the size of the perforation and what is the time elapsed. But what is the most critical factor? Option B. So to this particular question, answer would be option D. This is not critical. Hemostatic agent of choice during vital pulp therapy. This should be VPT, that is vital pulp therapy. Hemostatic agent means there is a case we are attempting pulpotomy or something. Sodium hypochlorite, saline, chlorhexidine, cryotherapy. It should be very obvious that sodium hypochlorite application for 5 minutes is done to stop the bleeding from the pulp wound. If the bleeding does not stop for a 5-minute application of sodium hypochlorite, the inflammation of the pulp is irreversible. Vital pulp therapy cannot be attempted. We have to go with pulpectomy and root canal. So, sodium hypochlorite is the hemostatic agent of choice. It helps in distinguishing reversible pulpitis from irreversible pulpitis. Question number 17. The pulp capping agent of choice in pulpotomy is another form of vital pulp therapy. MTA, super EVA, fast setting calcium hydroxide, slow setting calcium hydroxide. Definitely MTA and other calcium silicate based materials. MTA and other calcium silicate based materials, they are the most preferred pulpotomy agents for pulp capping. Okay, so answer to this question would be option A. Super EPA can be used. Out of these two, fast setting and slow setting, we would prefer fast setting calcium hydroxide as compared to slow setting. But most favorable are the most desirable ones are the calcium silicate based materials like MTA, biodentine, bioaggregate, endosem, etc. Okay. White colored block of dentine, non-curious marked by arrow underneath its normal yellow dentine is their aroma. The figure is missing from here, but if we talk about the zones of the dentinal caries, then there is the soft, then there is a firm, then there is hard, and there is finally reparative. 1, 2, 3, and 4 from outside to inside. These 3 and 4 zones, they are affected dentine, and the upper 2 zones which have to be removed, they are infected dentine. The outermost zone is the most soft, then the firm, then hard, and then the reparative form. Okay, so we preserve the zone 3 and 4, that is firm and reparative, and we remove the firm. We preserve zone option A and option D. We remove option B and C. Okay, these are the 4 zones from outside to inside. I think this is not related to my subject. Not used as a crucible former. Crucible former, whenever we do casting, we use a crucible to place the molten metal inside it. Glass, metal, rubber, or plastic. Okay, plastic crucibles are there, but it should be metal, rubber, and glass. Normally, we do not use glass crucibles. Okay, metal, rubber, and plastic crucibles are there that are used. Question number 20. Not true about IADT, International Association of Dental Traumatology 2020 guidelines for avulsion. I do not know what is the perfect language. Not true about IADT guidelines for trauma without alveolar fracture is avulsion 2 weeks. It should be for splinting. Duration. Avulsion 2 weeks, extrusion 2 weeks, intrusion 4 weeks, lateral luxation 2 weeks. We have already seen the duration of splinting for the various luxation injuries. I hope all can answer this question. Avulsion 7 to 10 days is done is true. Extrusion 2 weeks, intrusion 4 weeks, lateral luxation for 2 weeks is incorrect because lateral luxation also we do for 4 weeks. So option D is the answer. It is incorrect. The duration of splinting for lateral luxation would be same as intrusion, that is 4 weeks. Okay. We have to, it is a picture based question. Hygienic rubber dam clamp is used for the isolation of. Now this is a number 212 retainer. That is cervical retainer used for class 5 tooth preparations. So anterior, molar, premolar, partially erupted, it is used for anterior teeth mostly. Okay, you can easily identify this retainer, rubber dam retainer, in that it has got two bows. Okay, it is used for class 5 restorations mostly on anterior teeth. Okay, for partially erupted teeth, we use SG clamp, that is Silker Glickman clamp. Okay, this is a clamp with extended jaws to engage multiple teeth. It engages multiple teeth. SG clamp or Silker Glickman clamp. It is used for partially erupted teeth. What is shown in the picture is the number 212 cervical retainer, mostly used for anterior tooth preparations, so anterior teeth. Answer this question will be option A. It is not JADT, it is IADT. Not JADT, but IADT. It stands for International Association for Dental Traumatology. It is the parent body that gives the various treatment guidelines for the cases of different types of dental traumatology. Okay. Yes, it is an example of a winged clamp. This is the wing. But basically it has got two bows. It is a very typical clamp you can see. Otherwise, the clamp is having only one bow. This clamp has got two bows. It is a number 212, a cervical retainer. Very clearly told you in the class notes also. Okay. This is all. These were the important questions that have been recently asked in your INICET examinations. With this, I conclude today's session. My best wishes to you all. Do well in your forthcoming examinations. Study well, be confident, and do well. Thank you very much for being connected with me. Good night, everyone.